And a very good morning to all the respected faculty members. So today we would be presenting CGR on quality improvement in neonatology, our department's learning curve. So every day in NICU, we face challenges. Some may be small and some overwhelming, ranging from a child hyperoxygenating on mechanical ventilation with moderate hypothermia, an improperly attached saturation probe, a temperature probe which is not at an appropriate place, a baby not receiving kangaroo mother care, endotracheal tube that is not being fixed as it should be, neglected alarms often leading to disastrous consequences such as pneumothorax. So these are not just one-off incidents, they are patterns that we tend to see repeatedly. But what if we see these challenges not as problems, but as opportunities, opportunities to change, refine, and improve? And this is where quality improvement comes in. So in this today's presentation, we would introduce the quality improvement in healthcare, the global and Indian perspectives on the impact of QI in neonatal care. How is it different from the conventional research methodology and the projects being undertaken at SGPGI over the last few years? So, over the past 2 decades, quality improvement has emerged as a strong movement in healthcare in the developed world. In a landmark report, Crossing the Quality Chasm, which was published in 2001 by the Institute of Medicine, they defined that there is a need to restructure the system of healthcare and it defined various elements of the quality improvement. They defined quality improvement as a degree to which health services for individuals and populations increase the likelihood of desired health outcomes and they are consistent with the current professional knowledge. In simple words, it provides a framework to the clinicians to provide best possible care for their patients. It mainly emphasizes on reorganizing the care within the existing resources, but it may also contribute to addressing bigger issues. But it is essentially not a fault finding exercise, but a problem solving approach within the local context. The various dimensions of quality of care has been defined by the in that landmark report are safety, timeliness, effectiveness, efficiency, equity, and patient centeredness. Talking of the global perspectives on the quality of care, improving the quality of care is essential to meet the health related targets of the Sustainable Development Goals, and thus, quality has now been embedded into recently developed global frameworks such as Ending Preventable Maternal Mortality and Every Newborn Action Plan. And it is a crucial element in achieving universal health coverage towards which all countries are committed. Talking of Indian scenario, a very recent projections published in 2024 from the repeated cross-sectional data of the 5 rounds of the National Family Health Survey from 1992 till 2021, they showed that going by the current trends of the mortality rates, India is very along with many other states and union territories, is likely to miss these targets, especially in the early neonatal and the post-neonatal phase. They also highlighted that the burden of the mortality, or almost 50% of the under 5 child mortality, is now being contributed alone by the early neonatal period or the first 7 days of life. And thus, there is an impetus to drive change, bring about changes or strategies to bring down the rate of the early neonatal mortality in this vulnerable period of life. And the investigators concluded that for as India develops a strategy for same, the focus should now be shifted from quantity towards the quality of the institutions where delivery and newborn care occur. This systematic review highlights the effectiveness of various strategies to improve the healthcare provider performance, especially in the resource limited settings, and they showed that quality improvement alone achieved a median effect size of 28% and up to 56% when it is targeted with clinical training. So, by integrating both, the impact on the healthcare provider performance can be maximized. Acknowledging its importance, even National Medical Commission in its latest guidelines for competency-based medical education has now made it mandatory that a minimum of one QI project must be carried out by a super specialty resident in neonatology. This slide shows how the quality improvement is different from the conventional research that we are more familiar with. So while research focuses on generating new knowledge, the focus or the thrust in quality improvement is to operationalize the best practices using dynamic protocols that are subject to change. So we carry out a process, we learn from it, and then we can change our protocols, unlike those in a conventional research where we have a static protocol at the starting of the research. So research mainly aims to answer new questions while quality improvement targets the meeting thresholds for providing better patient care at bedside. And since reporting guidelines are a prominent part of biomedical literature, so there are the SQUARE guidelines that are available for supporting the strongest and most definitive evidence on quality improvement, and they have been latest updated in 2015. So in today's presentation, we would like you to take you all through the journey of departmental of quality improvement and the methodology of QI, for which I would like to ask Dr. Anbarson to please take over.
So how to choose a quality improvement project? The first step in any choosing a quality improvement project is we should have a clear aim. So for this, the first of all, we want to know the problem we need or opportunities for changes made from the unit. From this, the existing quality indicators helps a compilation of such a list. From the list, we can learn to by using various criteria to the resources, probability of change, investment level, and practicality. The prioritization of the problem can be done by following the prioritization returns by the participants who are expert in the facility. So each of the problem should be given a score of 1 to 5, and the maximum score will be 20, and the minimum score will be 4. So the problem which has some scholar can be taken out for conducting the quality improvement project. From this, statement, how to change statement and develop the change ideas and test those change ideas through the rapid circle model, that is the study of circles. So there are 4 steps in conducting a quality improvement project. First of all, we have to identify the problem and form a team. The team consists of a team leader and faculty, doctors, and nursing staffs. And we should have a good written aim statement to improve the quality of care. In the next step, we have to analyze the problem and measure the quality of care. In the third step, we have to develop the change ideas and test the change ideas by talk what works, which change idea is going to work on this problem. After the testing these change ideas, if you have achieved a desired result, you have to implement these results and you have to sustain this improvement. So the last step of quality improvement project, sustaining its improvement is an important aspect. So conducting quality improvement project to healthcare settings. The important doing for improvement. But the simple and effective method to improve the quality of care is the for improvement, which are promoted by intersects. The champion by Institute for Healthcare Improvement, which was launched in USA in 1991. So, as I already told, for every quality improvement project, the first step is aim. So, what we are going to accomplish is the aim statement, and next comes the measurement. So measuring the quality improvement is the key aspect. So measuring the quality help us to understand what we are actually going to achieve and what we can learn from our previous attempts. Then next comes the change. So what change can we make that will result in improvement? So this change ideas can be tested by using the plan, do, study, act cycles. This is a methodology for conducting the quality improvement project. This is a cycle for learning and improvement. So already told aim statement. We should have a clear aim statement and it should be describing our problem. So the aim statement should be clear and specific and it should be described in four types, that is what, who, how much, why, when. So it describes the outcome or the process of the problem statement. It describes the people who are going to implement this quality project and how much it becomes from the achieve from the baseline and how the instance we are going to achieve a goal. So whenever we are making the aim statement, let's think of a spot. The aim statement is specific, actionable, achievable, relevant, and recoverable, and should be complete. So for example, the aim statement, we aim to increase, decrease, or improve the overall percentage or score of the environment that we are going to improve should be entered, followed by the number we are going to achieve. That is for 50%, 10%, or 40%, 50%, it explained later, and the division we are going to achieve should be explained. There are various tools used for conducting quality approval project and risk measurement. On this, the important the project chart, the technique, and process flow chart. The Pareto principle. The Pareto principle is also known as an 18-20% rule. So what does this principle states? It states that 80% of the problem of the effects come from 20% of the causes. So addressing this problem can lead to the changes of the 80% of the problem. So it can help the team concentrate the impacts on the factors with the greatest impact, and it also helps the team focus on the certain areas. So this is an example for a Pareto principle. Here, the type of education loss, which is a problem as occurred due to no stages or long time of the administration or dosage around patient. As we see from this level diagram, the writing few ultimately, for the writing few in the factor, that is the factors contributing to the problem. So you can see here which is the cognitive loss, which is followed by the 80% rule. So the 20% of the causes are responsible for 80% of the problem, which can be identified through the Pareto principle. Next comes the problem technique, that is a simple problem solving technique to identify the root cause of the problem. It often takes 3 to 5 days. That is, we have to ask a question, why this problem has happened. So the answer to the why should prompt an another, and the answer to the second why should prompt an so in this way, we can able to identify the root cause of the problem. Suppose, for example, here we can problem statement as important nursing handover while doing the shift change. So why this problem is happening? Because the nursing staffs are doing handover and there is no better documentation. Why there is one handover? Sometimes the staffs are in late or they are in hurry to leave. So why they are in late or hurry to leave? Because they are unaware sometimes of the importance of the return handover. So why this is happening? This is because lack of service policy or private to guide them. So at last, through this one technique, we identify the root cause of the problem as shortage of staffs and a busy schedule. Next comes the cause and effect diagram to identify the root cause of the problem. It is sample technique, number five technique to identify the root cause of the problem. In this, it is a visual aid displaying the relationship between various factors that contribute to a particular effect or a problem. It resembles like a bone of a fish. It is also known as Ishikawa diagram, which is named after its creator. So there is a criteria for writing a fishbone diagram. In the fishbone diagram, we want to make a vertical box. So the vertical box, in the vertical box, we want to have the main focus to problem that we are going to assess. Followed by, we want to make a horizontal line from the vertical diagram from the left to right. Followed by, we want to make a diagonal line between above the horizontal line. So this diagonal line is a fishbone of a fishbone diagram. This explains the possible main causes which is contributing to the problem. Then comes the short bones. The shutdown is the possible contributing factors or causes which are related to the main problem, and this way it is contributing to the forecast problem. So the fishbone diagram here is built can able to identify the root cause of the problem. Next comes the process flowchart. In the process flowchart, it is an organic tool for assessing the quality improvement project. It is like a process that flows on its way in the form of steps. So it can identify the problem in the steps. So always begin with the beginning and the end point. Always decide the beginning and end point of the steps of the process. You identify each steps and connect with the arrows showing its direction. So review the chart to see whether the steps are in the logical order. So this is an example of a process flowchart. Process flowchart. So while making a process flowchart, each step and each shapes are its own importance. The start and the start of the process flowchart is oval, and the next step which always happens rectangle, and thus the option diamond. Diamond is an option point which is used whenever it will lead to different options. And this clear, and this is the cloud, or unclear steps are used whenever we are sure what is going to happen. So next comes the PDC cycle, which is the change cycle within the quality improvement project. This methodology is used to develop the change ideas. So what is this PDC cycle? PDC is plan, do, study, act cycles. So in the plan phase, we have to describe the problem as already told and describe the current process, identify the root cause of the problem, and develop a solution plan. So in the do phase, we have to implement the solution plan that we have planned. Then in the study phase, we have to study the result to see whether our desired result was achieved, what we have learned and what went wrong. So it can be able to confirm the current performance versus the target performance. So in that phase, if a desired result was achieved, implement it on larger scale and continue it for further improvement. So that will be charts. That is the data which have been collected through the quality improvement project has been represented to in the form of incidence of outcome against the time interval. So these are the various graphical representation for measuring the results of the quality improvement project. This is a chart, this is a control chart, and this is the line diagram. So the POCA model, the point of care quality improvement model, which has been widely used in conducting quality improvement project in India, which was launched in 2017, jointly in association with World Health Collaborating Center of AIIMS New Delhi and World Health Organization Southeast Asian regions and assist. It provides a simplified approach for improving the quality of care in animals, newborns, children in healthcare facilities. Now we call upon Dr. Nagari to describe a currently undergoing project in based on the point of care quality improvement module.
A very good morning to all. Now, since my colleague has nicely explained the methodology of a QI initiative, now I would discuss the QI project which is presently ongoing in our unit. So to decide upon the problem area which we wish to improve, we prepared a prioritization matrix. It consists of different aim ideas, and each of the options has to be scored against various columns like importance to the patient, affordability in terms of time and resources, ease to measure, and whether it is under the control of QI team. The total score can range between 4 to 20, and the minimum score to be given in each column is 1 and maximum is 5. So this matrix has to be scored in a vertical manner. So once we score all these options in the first column, only then we can move to the next. And it was to be filled by all the healthcare workers. So after the scoring, we on analysis found that the highest score was received by the aim of improving duration of kangaroo mother care in stable low birth weight babies less than 2000 grams of weight. So step one of any quality improvement initiative is identifying a problem, forming a team, and then writing an aim statement. Kangaroo mother care is a standardized care for all low birth weight babies, and WHO recommends initiation of KMC among low birth weight babies after clinical stabilization. It is low resource, evidence-based, and a high impact intervention, and it decreases neonatal mortality and the risk of sepsis. KMC provided for at least 8 hours a day and initiated within 24 hours of birth results in the greatest benefits. But despite knowing all these facts, the overall KMC duration still remains low in various neonatal units. So what are the barriers in KMC implementation? The barriers can be at the level of healthcare workers or at the level of health facilities. So the most common barriers are that the nurses believe KMC is non-scientific, it is based on a perception only. There is restriction to the entry of caregivers in the ICUs, and there are concerns about stability of the baby while the baby is on KMC. Also, there may be logistic issues of space for KMC wards, insufficient space in the ICUs. It may lead to overcrowding. There is a short visitation time for the parents, and only few units have a written KMC policy. So now we began with the formation of a team. The team consisted of a team leader, 3 faculty doctors, 3 resident doctors, and 4 nursing officers. And the aim was to increase the duration of kangaroo mother care in our unit from a baseline of 4 hours per baby per day to 12 hours per baby per day over a period of 12 weeks. The study consisted of a baseline phase where the baseline duration of KMC and the percentage of eligible babies who were receiving KMC was noted down. And it was followed by an implementation phase of 3 months where a fishbone analysis was done and PDSA cycles were done to test the change ideas. So step 2, as we discussed earlier, is analyzing the problem and then measuring the quality of care. So fishbone analysis was done to know the root causes which were leading to lack of continuous KMC. So there were various causes like mother is most often unavailable in outbound ICUs, there's father entry restriction, there's lack of motivation among the healthcare workers itself, there's nurses concerned about the monitoring of the baby, mothers needing rest initially post-cesarean, and the KMC documentation was also not very adequate. Also, there was no separate ward for KMC and no stringent unit policy. But overall, we found that the most important cause was lack of motivation among the healthcare workers itself. In the baseline data collection duration, the process indicator was the percentage of eligible babies who were receiving KMC each day, and the outcome indicator was total KMC hours per day per baby. So in the baseline data analysis, we found that over a period of 4 weeks, on an average, only 25% of babies were receiving KMC among all of those who were eligible to receive KMC. And the total duration of KMC that they were receiving was only 4 hours per baby per day. Hence, now was a third step, that is developing and testing changes with the help of PDSA cycles. So the first PDSA cycle, which we began, we focused mainly on the training and teaching of the healthcare workers, first of all. And we took various sessions because there were 49 nursing officers and resident doctors who had to be trained. So in total, around 14 sessions were done, and they were all interactive sessions where everybody could ask their queries and doubts, and they were explained the benefits of kangaroo mother care, they were taught the proper position, and the importance of vital monitoring during the procedure. Then WhatsApp groups were formed for communication among the team members so that the daily updates could be posted. Any challenges which were being faced, they could be discussed with each other, and the quality improvement team meetings, reminders were also put on that. Now, we try to analyze the percentage of eligible babies who are receiving KMC at the end of PDSA cycle 1. So now we can see that as compared to the baseline duration, when only 25% babies were receiving KMC on an average, now at the end of PDSA 1, around 73.4% of the babies were receiving KMC. And the baseline duration of KMC, which was just 4 hours per baby per day, that had also increased to 7.6 hours per baby per day at the end of 4 weeks. But now, since our aim was to reach up to 12 hours per day per baby, now we began with the second PDSA cycle. So during the first cycle, we realized that the healthcare workers were now trained and taught, but still parents were finding it difficult to understand proper KMC position. KMC documentation was also not appropriate. Hence, we prepared these posters that were displaying the kangaroo position. And we had displayed all these posters near the baby's cots so that the parents could watch it and could understand what is the proper position of providing KMC. And also in the second cycle, we emphasized more on foster KMC. That is, if the mothers are unavailable or they are not able to provide KMC due to any reason, other family members like father, grandparents, they could also provide KMC to the baby. So in this slide, we can see in the first image, mother is providing KMC. Second, she is grandmother. And in the third one, father is providing KMC. And in the fourth one, grandfather is providing KMC. So the need of alternate care provider was also explained. Now, improving the documentation. Earlier, we were collecting the KMC data on a recall basis. Hence, we prepared this KMC documentation chart. It consisted of the baby's name, CR number, diagnosis, and the nursing officers had to fill the duration of KMC in their shift. This was to be followed by their name and signature. And it was also cross-verified by the SR or faculty for a proper documentation of KMC duration. A simple data collection form was also prepared, which was daily displayed on the notice board. It had the date, number of eligible babies for KMC, number of babies who were actually receiving KMC, and the average duration of KMC per day per baby. We also displayed this run chart every day. So this whiteboard, it mentioned all the eligible babies for KMC on that day. And the run chart also, in the form of a line diagram, we tried to show it every day so that we could monitor the progress of the project. And the KMC duration was also mentioned on the whiteboard. Now the process indicator, that was the percentage of eligible babies receiving KMC. So since we can see in this graphical representation that at the end of PDSA 2, 76% of the babies were now receiving KMC. So earlier there was a remarkable change in this percentage compared to the baseline data, but now there was increment, but still it was not very significant. But the KMC hours, if we see, at the end of PDSA 2, now the KMC duration was 9.9 hours per baby per day. That was very much better than the earlier one. But to achieve our aim, now we began with the third cycle, that focused mainly on the parental counseling. So we prepared these structured pamphlets to distribute to the parents. We mentioned all the common questions, the common doubts, and we provided an answer along with it. And these images are of our unit itself. And we tried to cater to the common queries. This was distributed to all the parents of low birth weight babies. Also, we started collecting feedback from the parents. So those babies who were discharged and the parents who were doing it properly, they provided us feedback on KMC experience, and we utilized this feedback to motivate other parents as well. So most of them found it beneficial for the weight gain of baby and early discharge. We conducted various counseling sessions for the parents. The counseling was incorporated in the daily and ICU counseling. And in the ward also, any member of the QI team could counsel the parents every day. So these are the different images showing the same. And on analyzing our process indicator, we have done 3 weeks of PDSA 3 now. And now 85% of the babies are receiving KMC among all those who are eligible. And also we could reach a KMC duration of 11.2 hours per day per baby now, which is close to reaching our aim. This is a run chart, which is showing the KMC trends on daily basis. And we can see the fluctuating trends in KMC. But if we see the median KMC hours, in the first cycle, it was 7.1 hours per day per baby. In the second, it was 8.5. And in the third, it was 10.5. Now, the most important step of any QI initiative is sustaining the improvement. We do not wish to go back to where we started. Hence, we decided to have a provision of adequate beds and KMC chairs, emphasis on the need of alternate care provider, structured counseling of parents will be continued each day, and we have decided to include KMC hours column in the vital sheets itself so that it is not cumbersome. KMC rates will be presented in monthly perinatal statistics, and monthly review meetings will also be done by the QI team to monitor the progress and to discuss any challenges being faced. Also, we have planned for a written unit policy. Nursing teaching sessions will be continued once a month so that any new recruitment, they also are taught and trained, and the older ones are reinforced. And celebrations and incentives will be provided to the QI champions. Now, in review of literature, we found that many other centers have also conducted such QI initiatives to increase the KMC duration in their units. But we realized that the challenges of every unit are different. And everybody has tried to cater to the problem in their own different way. Hence, the challenges can be different. The PDSA cycles can be different. But overall, our aim is to have interventions targeted to the complexities of the local setting. And most of the centers had aimed for around 6 hours per baby per day of KMC duration. And we at present have achieved a duration of 10.5 hours per baby per day, and we are still putting in hard efforts to reach our aim. Thank you. Now I would like to call Dr. Bushra to give an overview of the other projects which have been done in our unit.
Good morning, everyone. I'll be talking in brief about the quality improvement projects that we have done in our NICU based on the EPIC and the POCI module. Starting with the project 1, reducing the infiltration rates of the peripheral IV cannulas in our NICU. The aim of the project was to study the baseline IV infiltration rates and to reduce the infiltration rate by at least 30% from the baseline. To achieve our aim, a baseline infiltration data was calculated as number of reported IV infiltrates each month divided by monthly total IVSS indwelling each day. And the baseline infiltration rate was 4.6 per 1000 IV days. And the average duration of working cannula was 18 hours only. And it fall into the grade 3 of IV infiltration, which is the pain with the swelling and the blanched skin at the site of IV extravasation. We use the fishbone analysis to identify the root cause of this problem, and the major barriers identified were inadequate knowledge of insertion of IVSS, inability to identify early stages of infiltration, absence of unit policy on steps, and the maintenance of IVSS, which led to the inappropriate fixation of the IV cannulas and increase in the infiltration rate in our NICU. To tackle this problem and to implement the change ideas, a PDSS cycle was used. Various training sessions were conducted in which the nursing staffs and the resident doctors were educated regarding the preferred site of putting the IV cannulas, how to fix the IV cannulas using the transparent dressing, and for the early identification and the preventive measures of any IV extravasation with the help of PowerPoint presentation, visual aids, and the bedside skill teaching. With the help of all these measures, we were able to change the fixation style from the old technique to a new technique of using the transparent dressing, appropriate size splint at the appropriate site. We made a unit policy featuring the appropriate site selection with the avoidance of joints or the already infiltrated area, closely monitoring of IV cannulas by checking patency before giving any infusion, use of extension line, and the documentation of any IV extravasation event. Attribute U chart was used to display and to interpret the serial measurement of the indicators. This study demonstrated a gradual decline in the infiltration rate from 4.6 to 2.4 per 1000 IV days, with the improvement in the duration of the cannula from 18 hours to 42 hours, with the help of all these unsophisticated existing measures. This quality improvement project has been published in the Indian Journal of the Child Health in 2019, and Dr. Asta ma'am has received gold medal for this quality improvement project. Next two projects were done as a part of sincere collaboration with the Canadian Neonatal Network, and it was based on EPIC module. In our NICU, all the resuscitation drugs and the equipments were available, but it was not organized to a single place. Past attempts to maintain the resuscitation carts often failed because the items were not replaced consistently. To address this, we implemented this quality improvement initiative as ensuring the daily organization of emergency resuscitation cart in our NICU. The aim of the project was to develop a designated mobile organized emergency trolley and to improve its adherence in all the 3 shifts, and to improve the completion from 0 to 80% over a period of 12 weeks. We tested our change ideas with the help of PDSS cycle. A checklist was formulated of all the emergency items and their drugs, and all these items were procured, and an emergency crash cart was created with the proper labeling of all the items. A designated nursing staff was assigned to check and restock the emergency cart in each shift, ensured its availability 24/7 at the bedside. Weekly meeting was conducted to analyze the results. A social media platform was used for the communication for the positive reinforcements and for the reminder. To encourage their active participation, a certificate of appreciation was given for their best work. The results were plotted on the run chart. During the PDSS cycle 1, The percentage of item completion was reached to 80 to 85%, and it was sustained to 100% in the post-implementation phase. After implementation of this quality improvement project, a structured checklist system and a designation of the nursing staff was sustained. On random audit, we found that the percentage of item completion was not sustained to 100% because of the missing of some drugs. But we were able to achieve the completion rate of 60 to 80%, which was much better from the unstructured system we had before. Coming to the next project, as there was no structured and the proper protocol of the nursing handover in our NICU, which led to the medication error during the treatment of the neonates. Hence, we conducted this simple quality improvement initiative as ensuring the daily proper written handover in each shift in our NICU. The aim of the project was to improve the proper handover in all the 3 shifts and to improve the completion from 0 to 70%. A fishbone analysis was used to identify the root cause of the problem, and the major problems identified were late arrival of the nursing staffs to take the over of the baby, sisters were taking handover at the nursing desk, they were not taking bedside over, and there was no standard checklist of written handover, nurses were not assigned to the babies, and lack of supervision. We used the PDSS cycle to implement the change ideas. We created a checklist and it was made available bedside for the information and the implementation. The nursing staffs were oriented to the new checklist, how to fill the checklist, and what is the effect of this checklist on the patient care. To motivate the nursing staff, every day handover percentage was displayed on the unit board, and the WhatsApp group was created for the positive reinforcements and for the messages to improve the clinical practice, and the certificate of appreciation was given for their best work. During the PDSS cycle 1, the compliance of the nurses to the written handover was reached to 70 to 80%. While in the post-implementation phase, there was a gradual decline, indicated that the process was not fully sustained. The reason might be the complex checklist, which the nursing staffs found difficult to follow. But after this project, the nursing handover was changed from verbal to the written handover with the help of the handover register book, and the nurses are assigned to the babies in each area of the NICU, which reduces the confusion and streamline the handover process. The poster presentation of both these projects was done in 2022 at the National Neonatal Audit Program organized by RCPCH, and it was also presented at the UP Neocon in 2021, and Dr. Abhijit sir has received award for this quality improvement project. Now, I would like to invite Dr. Akansha ma'am to conclude this session. Thank you. Thank you, Usha. So, having gone through all these projects, we would like to point out some of the challenges faced while conducting these. The most significant challenge is to sustaining a dedicated team, because ongoing training, retraining, and maintaining enthusiasm can be difficult. Motivating all stakeholders, starting from clinicians, nursing staff, and administrators, can be difficult because it requires a lot of time and effort. Gathering reliable data again demands time and human resources, often competing with the clinical and departmental duties. And the most significant problem is maintaining the momentum. Even the successful QI initiatives may lose momentum if there are no ongoing supports or review mechanisms. And for addressing larger or more complex initiatives, it may require higher level backing from resources and some policy changes. The way forward seems to be benchmarking, that is learning from the comparing our processes and outcomes with other units that are performing well in the area of the interest. It may be suggested to use digital and e-learning tools such as virtual training modules or the smartphone applications to make the QI methodology available to a broader audience. Some existing neonatal databases such as National Neonatal Perinatal Database Network a network for comparing the outcomes of the very low birth weight babies across the Indian centers, that is VISHI, and an online database platform such as Indian Neonatal Collaborative, which is run by PGI MER Chandigarh, which collects quality indicator data from almost 12 centers, including ours. So all of these databases may be used as may be used to integrate the QI initiatives. And collaborative neonatal networks have been a prominent part and a standard of care in most of the high and middle income countries. And some collaborative networks from North America, Canada, and California have contributed prominently to the quality improvement initiatives. India is a part of the Quality Equity Dignity Network of WHO and UNICEF to improve the quality of care for maternal, newborn, and child health, to which 8 other countries are signatories. And in sync with this agenda, a self-sustaining network for carrying out the QI initiatives in India was formed, which was in 2016, which was subsequently named as the Nationwide Quality of Care Network. And this network has has used the point of care QI module to form an online digital community of practice to reach to the broader audience at all the levels. So all of us all can teach and learn the quality about the quality improvement initiatives. We can learn from the superior performers and implement in our context. So to conclude, quality improvement helps us to bridge the gap between what we know and what we are actually doing bedside, not as a one-time fix, but as a continuous structured process that can help making our units safer, efficient, and more effective for the patients under our care. We would like to acknowledge all the neonates under our care, the nursing staff of the NICU, since without them, any QI cannot sustain, the experts from Canadian Neonatal Network who helped us in carrying out 2 projects, our elite pediatric super specialties, Department of MRH and Pediatric Surgery. Thank you.